Good day. On behalf of Echosens North America, I'd like to thank you for joining today's webinar entitled Obesity and Fatty Liver Disease, Twin Epidemics. I am your host, Jerry Mayberry. In this webinar, Dr. Carolyn Apovian will present information on the pathophysiology of obesity, metabolic syndrome, and fatty liver disease, and emphasize the importance of effective lifestyle management. Today's webinar is funded by Echosens North America, the inventors, manufacturers, and distributors of the Fibroscan technology. This presentation includes information on the uses of the Fibroscan technology from published literature. Echosens does not intend to make any specific claims found in the presentation. The Fibroscan is FDA cleared as an aid to the diagnosis and monitoring of patients with chronic liver disease as a part of the overall assessment of the liver and is not intended for the treatment of any specific liver disease or condition. Please be aware that all participants are muted to Cystides and nutrition. She is also the past president of the Obesity Society. Dr. Apovian is ideally suited to inform us on the latest strategies in obesity and metabolic disease management. Now I will turn it over to Dr. Apovian. Doctor.
Thanks, Jerry, for that kind introduction. As you know, we're here today to talk about obesity and fatty liver disease. Obesity has been rising in prevalence for really the past 50 or so years, starting to rise dramatically in the 80s. And it was really in the 1980s that we really discovered that NAFLD is a disease, that there is a progression of fatty liver to NAFLD and NASH and cirrhosis. And this was really research starting in the 1980s. The pathophysiology of non-alcoholic fatty liver disease and its relationship to obesity. We'll go over epidemiological data, pathophysiology, and then treatments, the role of diet and exercise, the role of exercise alone, medications and surgery, bariatric surgery that is, and how we can improve outcomes and adherence, and a look at the future. This schematic shows you the prevalence of obesity and also diabetes among United States adults over the years starting from 1994. And at the top you see obesity prevalence rates, and you see that in 1994 there were states with a obesity rate of less than 14%, and many between 14 and 17.9% in 1994. BMI over 30 is what we're talking about. And as we hit 2000, we started to see some red states, which meant that the BMIs over obesity were hitting 22 to 26%. And then in 2015, you see some darker red states where the obesity rates are greater than 26%. And now we know that obesity has hit rates of 33% in this country. Diabetes, on the other hand, has also risen. Now, the rates of type 2 diabetes are lower than the rates of obesity. However, you see the rise from 1994, where most states were under 4.5%, and then in 2000 heading towards 6%, and then now in 2015 we see many states with a type 2 diabetes prevalence of greater than 9%. So those certainly are two epidemics. Now, what does NAFLD have to do with this? First of all, there is a continuum of non-alcoholic fatty liver disease that goes obviously from the normal liver, and you see beautiful hepatocytes here. And then what is steatosis, or NAFL? Steatosis is basically fat in the liver fat being stored in the liver, but without inflammation or hepatocyte ballooning, as we call it. And you see fat being stored in the liver on histological view. NAFLD progressing to steatohepatitis or NASH, non-alcoholic steatohepatitis. What does that mean? It means that inflammation is now present. The infiltration of fat in the liver with macrophages and T and B cells, and also hepatocyte ballooning and disruption of hepatocytes. And then the end result of this in the continuum is cirrhosis, where you see progressive fibrosis leading to the cirrhosis, and then eventually, in some cases, hepatocellular carcinoma. And we know that the progression to these three, 20% of patients with steatosis will develop NASH, and 20% will move on from NASH to cirrhosis. That's a little bit about that pathophysiology. Now, what is the role of diet, exercise, and most importantly, adipose tissue in the development of NAFLD? Well, the key to understand fatty liver is adipose tissue. So when a patient has obesity, it's not just that we have more fat. It's where the fat is. So fat that's stored in subcutaneous depots is generally beneficial fat. What's beneficial fat? It's just fat that is a cushion. It produces beneficial cytokines like adiponectin, which promotes insulin sensitivity. But in obesity, and in particular in obesity where fat is stored around the organs and in the liver and around the heart, it is this dysfunctional fat. That kind of fat releases non-esterified fatty acids that go to the liver, and the liver doesn't have great mechanisms to prevent the infiltration of that fat into the liver. And this is exacerbated by an unhealthy diet. So what's an unhealthy diet? It's a diet that's high in fat and sugar, high in saturated fat and sugar, that exacerbates the fat storage dysregulation, so that people who cannot store their fat subcutaneously because of fibrosis subcutaneously end up storing it in the liver and also viscerally. So in addition to that, because of unhealthy diet, because of the excess adipose tissue, there are elevations in insulin levels. The pancreas starts putting out more insulin to get rid of the excess calories, and then we have hyperinsulinemia and insulin resistance. And so the insulin resistance drives what we call de novo lipogenesis, and de novo lipogenesis occurs when there's a lot of simple sugar that the body has to do something with, and it stores fat from the carbohydrate. And that's what happens. The de novo lipogenesis continues to store fat in the liver and also in other places. The amount of fatty acids in obesity is double or more that in a normal weight person. So there is disruption of the adipose tissue, expansion of adipose tissue into ectopic depots, including, unfortunately, the liver. A little bit more, it gets even more complicated than that, and this is a schematic showing the metabolic players and pathways involved in non-alcoholic fatty liver disease. Basically, you have systemic insulin resistance, which I was just talking about, elevations in insulin causing resistance at the muscle level, at the fat level, and in the liver. That resistance reduces adiponectin levels and increases leptin concentrations. These are hormones that are disrupted in obesity. And adipose tissue lipolysis is not suppressed, not suppressed, so that we end up having pathogenic lipolysis. Meanwhile, there's fatty acids and glucose that has to be stored, has to be disposed of. So despite the high circulating insulin levels, plasma free fatty acid concentrations are increased. We also see an increase in glucagon levels, and that altered ratio of these hormones produces de novo lipogenesis and gluconeogenesis in the liver, and increases glucose production and hepatic insulin resistance. And so we develop non-alcoholic fatty liver disease, storing fat in the liver. We also see impaired GLP-1 secretion, so in the liver of patients with NAFLD, and that further impairs hepatic glucose and lipid metabolism. We also have ghrelin, which is activated. There's more ghrelin secretion in patients with obesity and in patients with NAFLD. And so this creates a vicious cycle where we continue to have excess calories trying to be stored by a defective system. We also have liver hepatokines that are produced. One is SEP down here, which enhances insulin resistance and increases the production of small LDL particles that develop, as we know, this develops a high risk of cardiovascular disease from endothelial dysfunction and atherosclerosis. And this is how NAFLD and diabetes and obesity can produce an elevated cardiovascular risk. So the adipose tissues secrete leptin and lower adiponectin that are involved in this fatty acid oxidation and production of inflammation. So that is more pathogenesis. And this is a more high-level overview of the whole thing. So we have adipose tissue dysfunction, insulin resistance, and increased lipolysis, which produces a lower level of adiponectin, more leptin, more free fatty acids, elevation in cytokines and adipokines. This all leads to inflammation, intrahepatic fat accumulation, and then the inflammation then leads to the a production of adipokines, which lead to fibrosis. Then you get cell death, apoptosis, and scarring, which leads to cirrhosis. So not everyone that starts with fatty liver disease develops NASH and then develops cirrhosis. Is about 20-20-20. But that's essentially the pathophysiology. And here's the 20% rule for progression in NASH. So you have those who develop some fibrosis. About 20% of those patients progress to cirrhosis. And then about 20% of the patients who have some cirrhosis progress to hepatic decompensation. You can fix things out here with NAFLD. You can fix things with NASH. You can even fix things with cirrhosis, especially if you do bariatric surgery. But here is where, there's decompensation, and you really cannot prevent that decompensation once you get past a certain point. All right, let's talk about where you see non-alcoholic fatty liver disease, because this is a difficult problem because we have patients who have diabetes and patients who don't have diabetes, and both can have fatty liver disease. So here we see the prevalence and the burden of NAFLD in patients with and without diabetes. So the big orange bars are those folks with diabetes, and the gray is the general population. As you can see, and along the x-axis we have plasma ALT, CT, liver ultrasound, Fibroscan, and the research MRI spectroscopy. And as you can see, we can pick more and more NAFLD fatty liver prevalence by the more accurate procedures, but basically you see that in type 2 diabetes you have more prevalence of fatty liver disease than in the general population, as you would expect. However, you still see a lot of fatty liver disease in the general population. It looks like about a third of patients in the general population have non-alcoholic fatty liver disease. And notice that very few are picked up by looking at LFTs. Okay. Now, here is a schematic that tells us that there are many patients who have NAFLD and NASH with normal plasma AST or ALT. So if you look at this is in patients with diabetes, we know that in diabetes maybe 2/3 of these patients have too much fat in the liver. So you look at the liver enzymes and see if they're elevated. We do see significant damage to the liver even with normal ALT and ALT levels. And what does it look like? These are patients with diabetes and normal AST, ALT evaluated for liver triglyceride content by spectroscopy. So the prevalence in the overall cohort here is about 50%. And among these patients, 56% already have NASH, and these are patients with normal AST or ALT. And here on the x-axis you have the obesity by category of BMI. So in the non-obese, you have about 36% prevalence of NAFLD. These are patients with normal AST or ALT. Now, if you have a patient with a BMI over 40, most of these patients have some fatty liver. And in class 2 obesity, BMI 35 to 40, you have about 68% of NAFLD prevalence. How are you going to pick these up in patients with normal AST or ALT without doing some kind of imaging? As we know, liver biopsy is quite aggressive, so we need imaging studies for these patients. Now, another thing is that LDL particle size is reduced in fatty liver disease, and this graph shows what happens to LDL particle size in patients with NAFLD. The lower bars are increased cardiovascular risk when we look at particle size. So you can see that even if you're not obese, too much fat in the liver is associated with a decrease in LDL particle size and increased cardiovascular risk. Now, how do you have patients without obesity have NAFLD? Well, these are the patients who have, we call them patients who are lean, or they look lean, but they have a lot of visceral body fat. And in the Asian population, this is quite common. And also in the South Asian Indian population, this can be quite common. So we had to reduce the cutoff points for obesity in this population to a BMI of 23. Okay. How about let's talk about diet and exercise now. In how can we treat NAFLD? So we know that patients with obesity and NAFLD have a lot of physical inactivity. Exercise has been shown to have benefits in fatty liver disease on its own, especially vigorous intensity exercise, and it can reduce NAFLD and also non-alcoholic steatohepatitis, and this is without weight loss. However, we also know that the benefits of weight loss plus exercise is much better than exercise or diet alone. So we need to talk about physical activity. The point here is that you have patients, and I have patients like this all the time, who tell me that they go to the gym, they don't see weight loss, therefore they stop going to the gym. You need to tell them that even if there's no weight loss, exercise is going to reduce the risk and severity of NAFLD and even NASH, even if they don't see weight loss. All right, so what kind of weight loss brings what kind of reduction in fatty liver? So this is from several studies. If you have a patient with steatosis, you can tell that patient that they can lose as little as 3% of their body weight and get improvement. Steatosis improves, and so does some ballooning and inflammation. So if there's some ballooning and inflammation present, starting to become non-alcoholic steatohepatitis, studies have shown that a 5%, so we talk about a 5 to 10% weight loss, reducing these histological findings if you do a liver biopsy. Can patients sustain that weight loss? Well, not everybody does, and that's why we talk about medications for obesity. If you want NASH resolution, so complete NASH resolution, you have to go a little bit above 5%, get to 7%, and here's again where we talk about 5 to 10% weight loss will reduce a lot of this. Much fewer patients can sustain that weight loss, that's very true, without medications. If you want fibrosis regression, greater than 10% weight loss. And how can we achieve that kind of weight loss here? Intensive lifestyle with medications. What medications are we talking about? The medications that we have for obesity treatment, there are 5 of them. Phentermine and topiramate, bupropion and naltrexone, liraglutide, orlistat, and phentermine alone. And we have very few patients sustaining that kind of weight loss at the end of a year without those medications. Now, weight loss, weight loss can be helpful, especially with fatty liver, but once it progresses, it can be more difficult. So if you lose 7 to 10% of your weight, you see NASH resolution. Now, this comes from a study of 293 patients or so who tried to lose weight. Patients were given general advice on losing weight, doing exercise, diet and exercise. NASH resolution means that the pathologist looked at the report and said you had NASH, and then afterward the report you didn't see that inflammation anymore. So if patients lost 7 to 10% of their body weight, 2 out of 3 had a resolution of NASH. If they lost more than 10% of their body weight, 90% had NASH resolution. All right, that's excellent. That's only 10% of your body weight. So if you weigh 250, that's 25 pounds. Now, if you look at the fibrosis, half of those who lost 7 to 10% had improvement, and 81% of those who lost more than 10% had fibrosis regression. This is fantastic. Steatosis alone, you see 100% improvement in patients who lose 10% or more. And that's the point. The point is that you get progressive improvement in fatty liver and NASH with progressive weight loss. Now, we talk about a very low-calorie diet. All of these other studies used the general decrease in 500 to 1,000 calories per day, so that these were caloric intakes of about 1,200 to 1,500 calories a day. When you talk about a very low-calorie diet, you're talking about 600 calories a day. That's very low. You're not going to be able to do that for more than about a month. But our patients who need to lose weight quickly to reduce their blood sugar, to reduce fat in the liver, to reduce their blood pressure. We can put on these very low-calorie diets. And you can see, this is a schematic looking at liver fat content on the y-axis and time on the x-axis. And you can see a dramatic decrease in fat content in the liver even after 1 week. But after 8 weeks, you see a dramatic decrease. So these are people who are able to stay on this diet for 2 months, basically, which can be very difficult. But the less calories you eat, the more quickly the fat is reduced in the liver. And this is what it looks like if you do a MRI. Liver fat in the liver here at baseline, and you can see that after 4 weeks of a VLCD, the fat just, as I've heard from a patient, melts away. And this is very helpful. For example, if you have a patient who's ready to undergo bariatric surgery, but they have a lot of fat in their liver, imagine the surgeon coming in here laparoscopically and trying to get to the duodenum to try and do a Roux-en-Y gastric bypass. They can't see that much. But once the liver fat is reduced, the liver shrinks in size and the surgeon can see exactly what they're doing. And this is what we do with patients who are about to undergo bariatric surgery. We put them on a very low-calorie diet for about 4 weeks and get reduction in liver fat. So let's look at what our guidance, what our guidelines tell us. So this is from the practical guide from the American Association for the Study of Liver Diseases, AASLD, in 2017, and it recommended weight loss to improve steatosis, and 7 to 10% weight loss to improve the majority of the features of NASH, including fibrosis. Exercise alone may prevent or reduce steatosis, and its ability to improve other aspects of liver histology remains unknown. Why is that? Because really what we want is the weight loss and the exercise, not just the exercise. Bariatric surgery should be considered in otherwise eligible patients with obesity with NAFLD or NASH. What is eligible mean? You're eligible if you have obesity or your BMI is over 40 or over 35 with NAFLD or NASH, or with diabetes, or with severe hypertension or some heart disease. So please consider bariatric surgery in these individuals, because bariatric surgery gives you 33% weight loss, better than anything else we have. All right. So that's the guidance. We have guidances from the NIH, from the Obesity Society and the American College of Cardiology and the American Heart Association that tell you that you should apprise your patients whose BMI is over 40 or over 35 that bariatric surgery may be an option for them. Can you recommend bariatric surgery in a patient with cirrhosis? That has to be considered on a case-by-case basis by an experienced bariatric surgery program, such as we find in our tertiary care centers. But we can do. So again, weight loss. How much weight loss to improve steatosis? 3 to 5%. 7 to 10% to improve the majority of NASH features, including fibrosis. Yes, exercise, and consider bariatric surgery. Reducing calories is important, certainly. What diet is best? Well, we have many prospective trials comparing various diets, and not just for NAFLD, but for diabetes, for obesity. And the bottom line is, pick the diet that your patient can stay on to get the weight loss. So again, very important, a summary here. Counsel all patients on diet, exercise, and lifestyle. Consider medications in patients with a BMI over 30 or over 27 with a comorbidity, and surgical approaches in BMIs over 40 or over 35 with a condition. What are the pharmacotherapies we're talking about? We're talking about liraglutide or Saxenda. We're talking about bupropion, naltrexone or Contrave. We're talking about phentermine, topiramate or Qsymia, or phentermine and topiramate alone, or orlistat. And what kind of weight loss can you get with diet, exercise, lifestyle? 5 to 8%. Difficult to sustain because you're not doing anything to reverse the pathological process of obesity. You need drugs to do that. Then you can get an 8 to 10% weight loss. Requires continuous use of that medication, obviously. Bariatric surgery gives you the only sustained 10 to 30% weight loss over the long term. Okay, what other drugs do we have available? Metformin is great. It improves insulin sensitivity at the liver, but you need the weight loss with the metformin to reduce the histological, pathological NAFLD and NASH. So it's not recommended for treating NASH in adult patients alone. Pioglitazone improves liver histology. However, the TZDs can cause weight gain, so their use needs to be very targeted towards patients who are lean and have NAFLD and NASH. The GLP-1s are excellent. Liraglutide has been shown to reduce NASH and NAFLD. This guidance is saying it's premature. That was in 2017. I'm sure we're going to see other guidances coming out in the future because we do treat obesity, NAFLD, and NASH with diet, exercise, and GLP-1s. What is the GLP-1 that we use? We use liraglutide or Saxenda or Ozempic semaglutide if you have a patient with diabetes. Vitamin E has been shown to improve liver histology. However, there's risks and benefits. There's some toxicity, so it was not recommended for NASH and diabetes or NAFLD without a liver biopsy. What about sugar? There is a higher fatty liver prevalence with rates of added sugar consumption. We know this. We have overfeeding in the United States, and most of that overfeeding is from overfeeding carbohydrate. And what kind of carbohydrate? Simple sugars. We also have studies that show a higher NAFLD prevalence with intake of sugar-sweetened beverages or total fructose. Sugar-sweetened beverages are usually sweetened with high fructose corn syrup, which is a little bit higher, dose of fructose than sucrose. But you know, sugar is fructose and sucrose anyway. So the idea that this is just from the fructose is hotly debated. Starch versus sugar versus high fructose corn syrup. Is fructose the problem? Well, there are many studies that show that liver metabolism differs for glucose versus fructose, and that fructose mainly contributes to the de novo lipogenesis, and that the glucose breakdown mainly generates liver glycogen. But remember that high fructose corn syrup has both sucrose and fructose, glucose and fructose. So it's debated whether or not we're talking about fructose alone or all sugars. High fructose corn syrup is typically 55% fructose, and sugars, simple carbs, are a disaccharide of glucose and fructose 1-to-1 ratio. So what? To me, so what? It's all the same simple carbohydrate bad stuff. Oh, sugar raises insulin levels. Of course it does, and that correlates with NASH histology. So we have sugar raising insulin levels, but overfeeding raises insulin levels. So it's not just the sugar we're talking about. It's other simple carbohydrates as well. Does a low-free sugar diet do anything to NAFLD histology? So this was a very small study that was an open-label trial of a low-free sugar diet, less than 3% of daily calories, versus a usual diet in adolescent boys with histologically diagnosed NAFLD. And lo and behold, yes, from week 0 to week 8, here's the low-free sugar diet. And here's the mean hepatic fat fraction. You did see a statistically significant decrease in fat in the low sugar diet versus the usual diet. And we need more studies to show that. Let's let that way. However, what about non-nutritive sweeteners and metabolic disease? There's a positive correlation between, non-nutritive sweeteners. What are these? Stevia and the other non-nutritive sweeteners that are out there, and obesity, but there's reverse causality here. So yes, we know many people with obesity start drinking diet soda, and it's correlated, but that doesn't mean that the diet soda caused the obesity. So you need to do well-controlled trials to show this, and these are epi studies that are not well-controlled randomized trials. In the Framingham study, diet soda was not associated with elevated ALT after adjusting for BMI, and sugar-sweetened beverages were associated with elevated ALT in a dose-dependent manner. I think this really tells you more than these correlation studies. All right, any other studies out there? Sugar-sweetened beverages versus non-nutritive sweetener beverages, so diet soda versus sugar-sweetened soda. Is there a difference? So the regular soda increased the liver fat, the diet soda did not. In this one study, a 6-month study of 60 overweight or obese patients given different drinks. Okay. And look at milk here. Milk was probably better than anything, milk and water. And here's the regular soda, regular change in liver fat, way high compared to milk, diet soda, or water. Short-term study. This is a 12-week study in 31 patients replacing sugar with non-nutritive sugar, and the biggest effect in those with a higher hepatic fat who also had a decrease in ALT. So those who had the biggest effect are those who had high levels of hepatic fat. And you do see a decrease with the non-nutritive sweetened beverages. That's fantastic. We need more studies like this. All right, so I'm not going to go through non-nutritive sweeteners and why they could induce metabolic dysfunction, except to say that, yes, we have a lot of central effects of sweet taste receptors that may alter the microbiome and make you have a greater appetite for other sweets. But these findings are inconsistent. And at this point, I tell my patients to stay away from sugar-sweetened beverages. They have to drink diet soda, go right ahead. The bottom line is added sugar increases the rates of obesity and NAFLD. Now, if you want to read more about the interaction of fructose, glucose, and the pathways that lead to elevated triglycerides and uric acid with fructose, here's the paper. The paper shows that the pathway to breakdown of fructose is different than the pathway breaking down glucose. And it's here that it's thought that there's a development of more uric acid and more triglycerides. But I think this is a moot point because even with high fructose corn syrup, you have fructose and glucose. You don't just have fructose. Again, this is another schematic from that paper which gives you a hypothesized reason for why fructose can cause worsening of hepatic insulin resistance through a decrease in beta oxidation of fatty acids, and then an increase in adipose insulin resistance. But this is also true of simple sugars. So the bottom line, what's the bottom line? We have the Harvard Healthy Eating Pyramid and Plate. There are other healthy eating pyramids. There's the Mediterranean diet. There is the DASH diet, which is a great diet with 27% fat, mostly healthy fats, 55% carbohydrate, and the rest protein. This is the Harvard Healthy Eating Pyramid, which tells you to eat healthy oils like olive and canola oil, more veggies, more fresh fruit, and whole grains if you're going to eat bread, cereal, rice, and pasta, and healthy protein. And that's really all you have to do, and to drink water. So the macronutrient content, the actual percent content of these are all over the place if you look at the DASH diet versus the Mediterranean diet. However, the bottom line is do not eat processed food if you can avoid it. Eat healthy food in each category. One more piece for that. Limit intake of sugars. Now, bariatric surgery. Why is bariatric surgery just the best option we have for extreme obesity and NAFLD and NASH and even cirrhosis? Because it actually changes the hormone milieu that goes from the gut to the brain. And whereas in most obesity you have the defense of a higher body weight set point, bariatric surgery lowers the body weight set point from a change in hormones. This is a study, a prospective study, that looked at bariatric surgery and looked at patients with obesity, with more than one comorbidity, no drinking. It was specifically targeted to look at liver. So liver biopsies were assessed by reviewers for fibrosis, NAFLD scoring to determine NASH. And what did they find? So percent of patients with diabetes before surgery, 25%, after 10%. Percent of patients with hypertension went from 49 to 37. Why so low? Because hypertension can be essential. Hypertension not having to do with the obesity. A lot of diabetes does have to do with the obesity. Serum triglycerides went down. Fasting glucose went down. These were all significant. Insulin resistance index went down. ALT went down from 30 to 22.8, and GGT went down from about 40 to 29. So these were all statistically significant numbers. So basically, in the end, what is the treatment of NAFLD and obesity? This is from a review in Metabolism. You have patients with obesity and non-alcoholic fatty liver disease. Certainly, the targets of weight loss to improve steatosis, greater than 5%, the inflammation, greater than 7% weight loss, and the fibrosis, greater than 10%. First step is everyone undergoes lifestyle modification, diet and exercise. Any kind of a diet that is limited in processed food and can reduce caloric intake by 500,000 calories a day is fine. Any exercise that combines aerobic every day of the week for 30 minutes to an hour, plus resistance exercise 2 to 3 days a week, all large groups. And if you don't get a 5% weight loss there, the second step is to add an anti-obesity medication. The two here that were recommended were orlistat, the fat blocker, or liraglutide. However, we have others: phentermine and topiramate, bupropion, and naltrexone. The third step, in patients who have BMIs of over 35 and NAFLD-NASH, bariatric surgery. Which bariatric surgeries do we have available? We have the Roux-en-Y gastric bypass, and we have the sleeve gastrectomy. The Roux-en-Y gastric bypass will give you 33% weight loss and excellent resolution of NAFLD and NASH, and sometimes even cirrhosis. The sleeve gastrectomy gives you 25% weight loss, but also, indeed, excellent resolution of NAFLD and NASH. So, in summary, NAFLD is a spectrum that is increasing in prevalence due to the obesity epidemic. We need to suspect and diagnose with non-invasive tools because the ALT misses about 50% or more of NAFLD. And we saw this in our center, where in our patient cohort at Boston Medical Center, 84% of our patients with obesity had steatosis, 28% had severe steatosis, and 25% had fibrosis. Only 13 or 14% of the patients with steatosis had an elevated ALT, and only 27% of patients with fibrosis had an elevated ALT. All right? So it's going to miss a lot of these patients. Treatment is weight loss by all means, diet, exercise, medications, and surgery. Thank you very much for your attention.
Thank you, Dr. Apovian, for that very informative presentation. We've been monitoring the participant questions during the presentation, and we will now read them for Dr. Apovian's response. To the participants, please feel free to continue to enter new questions on your computer screen as we answer the questions that we currently have. I would now like to introduce Dennis Mesh, Clinical Account Specialist with Echosens, who will be reading the questions to Dr. Apovian. Dennis, please proceed with the first question.
Thanks, Jerry. Dr. Apovian, the first question, does intermittent fasting have an effect on fatty liver? If so, what windows work best?
That is a great question. Wonderful. Thank you for that question. So, you know, first of all, why do we care about intermittent fasting, right? You know, we generally eat 3 meals a day, 2 snacks. Americans especially eat from, 7 a.m. in the morning until 11 o'clock at night sometimes. And why suddenly do we have this rage about intermittent fasting? Well, there's evidence in animal models, first of all, that we all run on circadian rhythms and the circadian clock. And there are actually cycles of gene expression in the body, in humans and in animals, that govern metabolism and even our behaviors. And they're regulated in humans in 2 ways. One, by light. So via, we have the suprachiasmatic nucleus in the brain, and by light, and also by clock proteins that are present in every single cell in the body, and they cycle within a 24-hour period. So the circadian rhythm regulates our metabolism, and we've evolved with these rhythms to promote healthy behaviors and activities during the day. So our physical activity, arousal, waking, eating, and also sleep, nighttime sleep, and fasting during the night. There's something positive about that. What is positive about that? Well, if you start eating in the middle of the night, your genes are, your metabolism genes that break down nutrients are asleep because of the circadian clock. So if you eat in the middle of the night, you're going to get, you're more likely to have glucose dysregulation and elevated glucose levels if your genes are such. So that's called circadian misalignment, and so it happens when food consumption happens at inappropriate circadian times, such as late in the evening. And studies, actually, there are studies out there that have reported impaired glucose tolerance with evening meals as compared to identical meals given in the morning. And so this impairment seems to be the result of lower insulin secretion and insulin resistance. So insulin resistance is protective. It's a protective mechanism to stop you from storing glucose as fat. It tries to stop you from doing that. But sometimes if we're overeating, hyperinsulinemia occurs and overrides insulin resistance, and that's where the problem occurs, because if you have elevated insulin levels, you store more fat, right? So in other words, what I'm trying to say is that although we need very, very tightly controlled studies, it seems that the studies that are out there suggest that early time-restricted feeding, i.e., what's early, 7 a.m. to maybe 2, 3 p.m., 7 a.m. to 5, 8 to 5, no later than 5 or 6. Daylight hours are when your metabolism is revved up to metabolize nutrients. And when you start eating into the nighttime hours, when dusk and beyond, you start to get more impaired glucose tolerance and more predisposition, therefore, to NAFLD and NASH. So, yes, so the daylight hours. And we're about to do the definitive, how do you study this? So how to study it is you take 2 windows of time, early and late, and you give the patient, the subject, the same number of calories. You have to really control for calories, because if you leave people to their own devices and you tell them you can eat all you want until 5 p.m., right, they're going to eat less because they can't get all the food in by 5 p.m. So you have to really control those studies. So long answer, but it was a great question.
Thank you. Second question. Given the figures and evidence you have displayed for the presence of NAFLD and NASH in those with type 2 diabetes and the associated CVD risk, what effect do you think NAFLD-NASH may be having on the severity of COVID-19 and the outcomes in younger obese patients?
So that's another great question. We are seeing that younger folks with obesity and diabetes have higher severity of COVID-19, and there's a much higher mortality. That, and of course the elderly, but in the younger patients, it's predominantly those with obesity and metabolic syndrome who are more likely to be intubated and due to COVID-19 and higher mortality. So while it's very hard now, after all I've told you that the AST and ALT, I'm sorry about, they're not liver function tests, of course. I should have known that, but I'm not a gastroenterologist, sorry. But yes, we're not, elevations in those numbers, AST, ALT, GGT, ALK-phos, you don't have to have elevations in those numbers to have NAFLD and NASH, as we saw certainly in our center where we're doing Fibroscans. So it's hard for us to test for the presence of NAFLD and NASH in the acute setting for those COVID-19 positive patients who are coming into the hospital and perhaps getting intubated. So we haven't been studying that. However, there is a Chinese study that does show that COVID-19 severity is higher in patients with NAFLD-NASH. So we think that it's certainly a factor, and it's because of, and if that's true, which we think it's true, it's because of the excess chronic inflammation that, you know, we think starts in the adipose tissue, in the visceral area, and then certainly affects the storage of fat in the liver. So the fat is accumulating in places where it's not supposed to be, ectopic fat in the fat tissue and in the liver, and that is, you know, obviously those patients have metabolic syndrome, so they are at higher risk for NAFLD-NASH, and hopefully when we get the studies out there, we'll see that yes, it's associated, severity of COVID-19 associated with NAFLD and NASH. Great question.
Thank you. Next question. Some of the patients do not lose weight despite being on keto diet, Mediterranean, intermittent fasting diet, exercise, and normal TSH and cortisol levels. What do you recommend these patients should do to lose weight?
So yes, so this is very common. Patients who have obesity and severe obesity may not long-term lose weight on any diet and any exercise plan because they have severe dysfunction of the pathways that go from the gut and fat to the brain, and they are defending their higher body weight point. They're defending that fat mass. And any attempt to help these patients lose weight, their hormonal changes will be such that their body thinks it's starving. So it can be very difficult for some patients, and we haven't figured out what exactly is the issue. We think that it is really the way the cells handle calories, but we haven't proven that yet. So, and these are patients on very low-calorie diets. They're not losing weight. So what do? This is when you need to add medications and consider bariatric surgery for those patients with a BMI over 40 or over 35 with a comorbidity. Why? So first of all, medications will take care of one of those dysfunctional pathways, the pathway that leads to appetite and satiety in the brain. So we have 5 medications that are called anti-obesity agents. Most of them work centrally to increase satiety hormones and decrease hunger hormones. So as long as the patient takes that medication, and these are most of them have been approved by the FDA to take indefinitely, they will be able to defend a lower body weight set point. How much lower? These medications can help you lose 5 to 10% of your total body weight. So if you weigh 250 pounds, these medications can help you lose 25 pounds and keep it off. That's the key. If you lose 25 pounds and you, by diet and exercise, and you don't do resistance exercise, so you haven't changed your body composition, you're going to regain the weight. Why? Because you haven't altered those hormonal changes. So the medications help those hormonal changes to defend a lower body weight set point. How does bariatric surgery do it? Bariatric surgery takes care of several pathways. So there's there is a bypass of part of the duodenum and small intestine that alters the secretion of several of those metabolic hormones. And then there's also a restriction of the gastric pouch that, again, the vagal afferents go to the brain and you have satiety. So for several mechanisms, bariatric surgery works, and it's permanent. Now, do some people regain weight after 2 to 5 years after bariatric surgery? Yes, they do. Why do they do that? Because they have strong genetic predisposition to be at a higher body weight set point in this environment. That takes over. However, bariatric surgery will permanently alter some of the pathways so that the patients will indeed defend a lower body weight set point. How much lower? You can get up to 33–35% weight loss with bariatric surgery. So those are the recommendations: medications and bariatric surgery for those patients who have a hard time losing weight with diet and exercise and behavior. Great question.
Okay, next question. Thank you. Can patients lose weight too quickly? What is the ideal weight loss rate, pounds per week?
So yes, patients can lose weight too quickly. And when they lose weight too quickly, they are not taking in enough protein, and they're going to lose fat and muscle. That's the definition of losing weight too quickly. All right? You're losing, if you starve yourself, you're going to lose weight, but you're going to lose half of it as muscle. So the general guidelines are that patients, on average, lose 1 to 2 pounds of weight per week. In the beginning, most patients will lose more than that, and much of that is going to be fluid because when you are on a low-calorie restricted diet, you have less insulin coming from the pancreas. Insulin is a natriuretic factor. Anti-natriuretic factor. It holds on to water and salt. And so when you drop insulin levels precipitously, salt and water are lost through the urine, and you lose water weight. So, but on average, eventually, you're going to get down to an average of 1 to 2 pounds of weight lost. If you lose more than that in the beginning, of course, you're going to get sludge in the gallbladder, and you can precipitate gallstones and cholecystitis as well. So 1 to 2 pounds of weight per week. And that will also ensure that you get some ketogenesis, so fat metabolism increases in fat tissue. You want to get the fat to be metabolized and not muscle. And so that will ensure that your protein intake is such that you can protect your muscle. You can also protect your muscle by resistance exercise while you're losing weight, so that will generate anabolism in the muscle. How much protein intake should you get in? 1.5 grams per kilogram of ideal body weight. That's roughly about 80 to 100 grams of protein a day. If you eat less than that and you're on a diet, you may lose some muscle as well.
Thank you. Next question, do you use telehealth services in your diet and weight loss programs? If so, in what ways and with what success?
So we have adopted tele-video health, absolutely, in our center. The entire system at Boston University Medical Center has adopted telemedicine since the COVID-19 crisis. And we are seeing patients through televideo and, reviewing their diet and exercise, talking about medications, getting symptomatology for the medications that we use. Are they having any side effects? Bariatric surgery is the guidelines just came out, the MISS guidelines on how to prioritize your patients who were set up to get bariatric surgery and had to stop during COVID-19. And it's all about, metabolic conditions. So if you have a bariatric surgery practice and you had to cut off surgeries for 2 months because of COVID-19, how do you open it back up? Well, at first you take the patients who have metabolic derangements such as elevated blood glucose, elevated hemoglobin A1C, elevated blood pressure, hyperlipidemia, sleep apnea that's severe, and you prioritize them for bariatric surgery. So that can be done through telehealth as well by making sure they have lost a little bit of weight prior to surgery, as I said in the talk, that so that the liver shrinks in size, and that metabolically they're ready for surgery. Now, you're going to have to get blood work to do that. They're going to have to come in and get blood work and make sure they're H. pylori negative, or if they're H. pylori positive, you go through the triple therapy before they undergo surgery. But we've been doing all of this through telehealth, and it's going very well.
Thank you.
I did talk about the VLCD and the ketogenic diet for NAFLD and NASH, and it certainly does improve NAFLD and NASH, and we are about to do a study looking at the protein-sparing modified fast. So all of you who are interested in VLCDs and ketogenic diet, the first ketogenic diet was the protein-sparing modified fast developed by my mentor, George Blackburn, in 1970. And he's published papers since then on the protein-sparing modified fast. That is the quickest way to lose weight and maintain muscle mass if it's properly done, which means that not only do you need to ensure that the patient is getting 1.5 grams of protein per kilogram per day of protein, but that there's adequate water, fluids, and vitamins and minerals, including a multivitamin, magnesium, potassium, phosphorus, and calcium. So I wouldn't do it if you're not an equipped obesity medicine practice or have a place to send a patient for the protein-sparing modified fast. It's a very, very intense diet that needs weekly monitoring.
Thank you, Dr. Apovian. We've now consumed all of our time. I would like all participants to know that we've had record attendance at this event, which tells us that we need to have ongoing programming with this sort of information. And thank you to Dr. Apovian for doing such a terrific job in bringing us up to date. And we look forward to hearing from you again in the future. All participants will be receiving a link to the recording of this event. Please feel free to use that link to listen again and pass it along to your colleagues if they would like to listen as well. On behalf of Echosens North America, I would like to thank everyone for their participation, and good day.